little, they were tiny little things and they were all little pictures and you would have to put them in a slide deck. And so if you talk to any person with gray hair, they'll tell you about how their slide deck fell over at least one point in their life and their whole talk got ruined. What I'm going to do today, I hope, is go through spine and try to go through what I've seen evolve and learn about spinal cord injury through multiple different ways. Just to correct Chris, I actually didn't get a business degree. I got a degree in quality improvement. Um, because it was funny when I was looking back, I was a math major. And just for the group, so you guys like me, I'm still a Red Sox fan. So I grew up a Red Sox fan. I've always been a Red Sox fan and still am a Red Sox fan. But I went back and I was a math major and I didn't really think business world would help me that much because I'm really into patients and taking care of people. And I really don't like the business side of medicine, but we could talk about that offline. And so there's something out there in the public health world called quality improvement, which is a great idea if you're looking for something to do because it teaches you all about processes. A lot of the thought came from the airline industry, and it really makes you think and work as a team. So that's my little plug for anyone who wants to do that. Really quickly, I know we have about an hour here. I'm going to go through my conflicts. Really shouldn't bother anyone. The only one that somewhat appropriate is called Spiderwort, and it's a spinal cord injury company. But I really am not going to be talking about that one. All right. So why are we here? And if anyone wants to interrupt me, I love that, or challenge me, or I think I can get questions. If anyone wants to put a question in the chat, feel free to do that. I have a little ADD, so I kind of like to answer questions along the way. So, we learned a lot from our vascular friends, and it's kind of interesting. And it hurts me to say that because Chris knew me. As a resident, I spent a lot of time with the vascular guys and really enjoyed vascular and thought it was fascinating. But for some reason, I fell into spinal cord injury and really dedicated a lot of my life to spinal cord injury. But one of the things you have to understand is when you get a spinal cord injury, it's not an all done deal. If you think you get a spinal cord injury, you get a contusion, and the spinal cord strokes out, then you really don't need to do anything. What we've learned is there's an area of injury to the spinal cord, and then there's another area called the penumbra. The penumbra is the area that we think you need to attack and revitalize. The problem is when I came into neurosurgery, if you have an Asia A spinal cord injury, and I'm assuming you guys know spinal cord injuries, Asia A is the worst spinal cord injury where you have no motor or no sensation. B means you have sensation. C means you have some motion. D means you have good motion. And E, and here's a little semantic for everyone. An Asia E is only a person who's had a spinal cord injury who's gone back to normal. And I will tell you, that's more uncommon than you think because most patients never get back to normal, particularly if you look at their hands or their hands intrinsics. Anyways, Ralph Marino wrote this paper right when I was during my residency. And what he showed is Asia A patients really did not do well when we were a resident, meaning the conversion rate was in the single digit levels. And we used to do something, and I'll give the analogy since Chris is here. We used to do something with similar to the aneurysms in the old days. You would take the patient, and if they had a spinal cord injury, there was no hurry to operate on them. We just sort of, took care of them, their systems, and went on. What we learned is, and I'm going to go through this, maybe we need to do things more fast and more organized. So with that, what we're going to do is I'm going to go through some of the lessons I've learned and some of the problems. And the good news for you, or at least I hope the good news, is you're going to solve a lot of these problems as I get older and retire. I'm going to give you what I think you just need to have some background information so you understand the entire world of spinal cord injury. We'll start off with some positive news, and then we'll go through the exam, radiology, and I'm not going to hit all these. Then at the end, I just want to talk about some of the things we've learned from spinal cord injury trials. I try to do as many trials as I can and give my patients the opportunity to be in trials because even the ones that don't work, you learn a lot. And lastly, if you're a functional person out there, this is going to be a little bit of an advertisement for you or a commercial because I think that is probably the way we're going to help spinal cord injury in the near future. All right. So first of all, again, the positive news. Again, Ralph Marino actually just recently retired, but another paper he wrote where he looked at the conversion rates. The conversion rates in spinal cord injury are drastically getting better. Incompletes are going from 6% to almost 17%. And most impressively is the quadriplegic patients' conversion rates are, again, almost 3 times higher. So if you look at it, you had about a 10% conversion rate when I started. That means going from an A to something else. We're all the way up to about 30% of spinal cord injuries that are ASIA A are converting, which is something I never thought would happen. And we'll discuss why this is. I think it's happening. No one has a great answer for it, but I think we can talk about it. Another good thing is, as much as we make fun of millennials, they are a lot smarter than we are. Seatbelts, airbags, not drunk driving, not diving into pools has drastically decreased the incidence of spinal cord injuries. So now I'm going to go through some of the problems. One of the problems is the ASIA exam or the spinal cord injury exam. The spinal cord injury exam is one of the most difficult things to do. And if you ever watch a rehab doctor do it, they'll spend about an hour to do it. And it's multiple different factors. However, this is why you need to get randomized trials. In a patient that you think that's a wide awake, alert, you're going to get about a 7% conversion rate. And again, this is an older paper, so you're now probably talking about a 20% conversion rate. But you're also basing your exam on people that are either still asleep, intoxicated, have concurrent head injuries. So there's a lot of things that can mess with our exams. Anthony Burns wrote this paper, and he showed 2 different things that were kind of interesting. You have, again, about a 3-time better chance of getting an ASIA conversion in someone who's an unreliable subset. Now, why is that important? Because people base their discussion of people's prognosis on their ASIA exam. And this is probably a take-home message for everyone. Do not tell anyone anything about their prognosis for the first 2 weeks after they have a spinal cord injury. Anthony Burns also looked at this, and he wrote a paper and showed that it is pretty much unreliable in the first 2 weeks. So whenever I deal with patients with spinal cord injuries, I always tell them it's a bad injury, it's not a bad injury, but I try not to give them percentage or numbers. All right, next bad news. All the data that I've written my papers on is not great. And so people love the American College of Surgeons database. Unfortunately, that database and most retrospective databases are not very accurate. And so just glean when you understand this is that this study went back into the charts of different patients and what they call the INSCI charts. And this was, I think, the Alabama group. And they showed the inaccuracy was in between 40 and 70%, depending on what you were using for the scales. So again, glean what you get from the literature, even in a prospective randomized study, what we have. And this is sort of for the residents. Who out there thinks that there's something called spinal shock? And this is kind of an interesting thing, and I've worked on it for a while. When I was a resident, there was a big belief that patients were in spinal shocks and you couldn't get an exam until their cremaster reflexor came back or their bulbar cavernosus reflex came back. Ralph Totino went through this and showed that people's spinal cord injuries evolve over different rates. And so there's something called a delayed plantar reaction, which is a Babinski test, which comes up at about 2 seconds late. That is probably a reflex that is a very bad prognostic indicator, but most of the other reflexes are kind of useless and they really don't help you that much. We actually just wrote a paper looking at the BC reflex and showed that it had no prognostic value in evaluating spinal cord injuries. So again, don't be the good news for the residents. Don't be hanging on your reflexes too much. We look at them and you can watch them evolve, but in spinal cord injury, be careful. I'm going to talk about this in a second, but don't believe everything you were taught in medical school. I don't know if you ever heard that one before. There's a large belief that the old Ralph Nader drawing and designs of what the spinal cord looked like are probably not accurate. And this is, Alan Levy and a guy named Bungie did some work on this, and this is an excellent paper if you want something to read about. It talks about the corticospinal tracts in the spinal cord, and they're probably not organized like we discuss in central cord injuries. And I'll stop and I'll talk about that for 1 second, because I think central cord injury is a very interesting area. All right. Now we're going to stop. Problem number 2. And this goes directly to all my residents, because at least in my institution, the residents love to sit in the call room and they feel like they're control pilots at an airplane station, where why get up and go see a patient and examine them? I can do everything I want sitting at my computer. So here's 3 patients, and there's 3 MRIs, and I took the axial images of them. And I love doing this with people so I can look in your eyes and see what you're going to vote for, but we don't have that. So I want everyone to guess which one they want to be. You can be A, B, or C. And with that said, you got to know me, because I'll tell you A is probably the wrong answer. And I'll show you why. And this is sort of to get to the point that is radiology, we take care of people. We don't take care of x-rays. So always go back and do your things. In this patient, the guy on the left is an Asia A. He's had an Asia A for 35 years. And he is got a complete spinal cord injury. The interesting thing is, if you look at where the arrow is at the bottom, that's the bottom arrow it almost looks like a normal spinal cord, which is, as me as a person who is a spinal cord researcher person, all you have to do is jump that 3 centimeters of abnormal spinal cord, and then his spinal cord gets normal. Now, remember, patients don't get transection with spinal cord injuries. Exceptionally uncommon. I probably have seen about 5 of them in my life, and they're usually thoracic injuries if they get a transection. The second patient is neurologically normal. He's a guy that I took an ependymoma out about 10 years ago, comes into clinic every year for a follow-up exam. And I'm like, oh my God. And he's 100% intact except for a little spasticity. And this guy is actually neurologically completely normal. And you look at his films and you're like, okay, he doesn't have a spinal cord. And interestingly, and I know you guys have, you do a lot of spinal cord tumors. My experience, if you do a myelotomy on someone, they get proprioceptor issues, no matter how small the myelotomy is. And so this guy had normal proprioception, and he didn't want to get a myelotomy. So we've been following him forever. Now it's been about 15 years. All right. So we know we can't trust the radiologist. How about when we compare spinal cord injuries? When I was a resident, the most average spinal cord injured person was a young male, 20-something years old, doing something he probably shouldn't have been doing, usually on some substance that was illegal. The issue becomes now is it's that person's grandfather now and grandmother. So most spinal cord injuries, and this is what we looked at our institution, we had an over 300% increase in age over 20 years. So the mean age of spinal cord injuries is going up higher and higher, which are making the patients more difficult. And this is a paper we wrote with NACTN that shows that about every year, the mean age across the country is going up by half a year. So it's a pretty interesting problem to deal with, because older people have completely different spines than younger people. So just remember we're dealing with a different population. And again, that's not just for me, that's for everyone. If you look at this, the top right, in the 1960s, at the age of 85, you died. I mean, so we had a nice pyramid as people got older. Nowadays, life expectancy is so good that the mean age is 78. The interesting thing is if you make the age of 78, anyone have any idea how long your survival is? The mean survival? It's actually 15 years. So that means if you hit 78, you got a 50% chance of hitting 93, which is pretty interesting, and kind of gives us a little kudos for everyone who says that us in medicine have not really done anything. And if you look at a lot of different scales, and I won't do that to you, we haven't looked as great as we should. All right, now we're going to skip a little bit, and this is kind of an interesting thought. When we talk about spinal cord injuries, we kind of lump them all into one big category. And I'm going to say to you that that's wrong. And I think we need to better break down our spinal cords into different categories. And I'm going to tell you, I think central cord injury is kind of a mild version of a spinal cord injury, and I'll explain why in 1 second. But when you go to a registry, this guy on the left actually is from Philadelphia, and he got in a fight with his brother, and his brother actually stabbed him in the back of the neck when he was asleep. And so that is a transection of your spinal cord, which you're not going to see that often. And then on the other side of the spectrum is a central cord injury. And this is sort of what I said before with Schneider's concept and Netter's concept of your tracks. And Netter's, if you remember Netter, I don't even know if you guys use Netter anymore, but that's the concept that everyone's taught in medical school about central cords. The interesting thing, and we'll get to this in 1 second, is with central cord injuries, it's a hyperextensive injury, and you pinch your spinal cord, usually not a fracture. The problem is, and this is Dr. Bunge and Alan Levy's work, is if you look at this patient who had a central cord injury, the central cord injury, this area should be injured, right? In reality, the black little dots are axons that are injured in a central cord injury. So this patient had a central cord injury. They took the spinal cord, they severed it, and then they radio identified the neurons that were injured. And you can see it's a diffuse injury of neurons. The issue becomes is why are your hands so affected? We predominantly have many more hand fibers than we do other fibers, and they're probably more sensitive. And so again, I'm going to go with it's a more sensitive, your spinal cord injury is a central cord is a less severe type of an injury than an other one, not a completely different injury. So that's just a different way to think about people. Oop. I just ended the whole talk. Sorry about that. You guys got that?
Yeah, sure.
All right, well, let me go forward now. Okay, sorry about that. And again, this is Alan Levy, and this is the paper I quoted before, which is probably one of the papers in the last 10 years that's influenced my thought about spinal cord injuries the most. The second thing about spinal cord injuries is they behave differently. Central cords, they behave differently than other injuries. And we're going to talk about timing of surgery because I've written a lot about that. And this was you're getting old because this was Decade of the Brain, which was a decade ago. But in the Decade of the Brain, we've evolved a lot. I was there in the old days when aneurysms, and I don't know if you guys knew this, but in the old days with aneurysms, what they used to do is take the aneurysm patients that ruptured and put them in the corner of the room. And if they survived, then what would happen is you would clip the aneurysm because no one really understood the whole vasospasm problem. Nowadays, you get a much better survival because you guys attack them very early. You stabilize the aneurysm, and then you treat the vasospasm. So in spinal cord injury, the question is you have a neurologic injury, and what should you do? And again, there was some degree of a stabilize the patient, let the spinal cord cool down, and then operate on them once that happens. And I'm going to give you an example. This guy was a 23-year-old gentleman, and I don't know if you guys see this, but the U.S. Army gives you a bonus when you join the U.S. Army. And so around here, a lot of them go out and buy motorcycles. He went out and bought a motorcycle and then drove off the road, came in, and it's 10 o'clock at night. And the question becomes this is his injury. Your exam is very difficult because he was intoxicated. He's got a mild head injury like we discussed. And what do you do? Do you come in at 10 o'clock at night and operate on this guy, or do you wait? And that the whole world is evolving on that. And I'll tell you what I do at the end. We wrote this paper, which is a very interesting paper. It was a cohort study where we took patients and we put them in early or late surgery. It was not randomized. We tried to do it randomized, but it really didn't work out that well. And long story short, it's really, at the time it was done, this is 2012, it was a study of operating on people early or earlier. The average time to operate on people, believe it or not, was about 72 hours when I started my practice, and up to a week. So this was kind of, a bunch of centers that were very aggressive. And so the mean time in the early group was 14 hours. And that was after injury, not after arrival thing. And so a lot of people will quote this Daskis paper, and I'm gonna give you guys a summary of it kind of interestingly. What it really says is this: if you operate on people very early, they have the best chance of neurologic recovery. However, the key is the more injured the patient is, the better chance they have to get that recovery. And why do I say that? Because if you look at the patients that did the best, they converted 2 different ASIA grades. So if you're an ASIA D, you can't be an ASIA F. It's really the ASIA A's and the ASIA B's that are the ones that have the best chance to change and convert. And that goes back to what I was saying earlier, which one of the reasons I think we're doing better with spinal cord injury is we're much more aggressively decompressing the spinal cord. And I'm going to show you some data about this. Here's the complete patients. This was a meta-analysis where they looked at early. And if you're into spinal cord injuries, you have to go back and you have to look at the different definitions of early. Nowadays, most people use 24 hours, but when I was a resident, it started at a week, and then it went to 72 hours and 48 hours, and now it's down to 24 hours. And I'm going to argue that early should be as soon as guy or girl hits the door. So these guys look, and if you know how to read a meta-analysis, the red line comes down and you can see the improvements with early surgery. So those patients get significantly improvement, about a 30% conversion rate. How about incomplete patients? Now, here's the kicker. Everyone wants to operate on the incomplete patients early. But if you're an ASIA D, guess what? You're going to recover. So those are the people that you can actually not operate emergently if you have to, figure out times. But everyone's so worried they're going to get worse. And don't get me wrong, I'm still one of those people. I'm just telling you that when you look at the data, it's the complete patients, either the motor completes or the sensory complete ones, that you probably should operate on the fast. So this was a study. They went out and they looked at the patients and they said, okay, who's going to operate on these patients early? And almost 40% of people say, I don't operate on ASIA A's earlier. So I guess my take-home message for you is, with a complete spinal cord injury, I get up in the middle of the night and take that patient to the operating room. And this is why. So this is another study with a meta-analysis, and then they went from the 24-hour patients, they break it down to 8 hours. So now they're looking at less than 8 hours. And again, if we look at the complete patients, they again do much better in terms of their recovery, and their odds ratio is almost about 7 to 8 versus the incompletes, which is a tiny bit. So you do get a little bit better with the incompletes, but you really do get a significant recovery with the complete patients. So I guess the take-home message for everyone is do it early. The sooner you do it is typically better. Now, the next question becomes okay, Dr. Harrop, and I guess I shouldn't refer to myself in my third person, my psychiatrist says, but when is that window over, or does it over? If someone comes in at 5 days, do I rush them to the operating room? And this is a paper by Jeff Wilson, and he looked at that and he took 4 different huge databases, 1,000 patients, and tried to understand what that is. And it looks like that early surgery benefit peaks out about at 36 hours. And so the question becomes, after 36 hours, you could argue, there's not a huge benefit from operating on people early. I still believe that you should try to do it, but a lot of times if patients, you're making that decision at 36 hours, they're very, very sick. And so just in the back of your mind, remember, it might not be as good. All right. Next thing we're going to talk about is processes and problems. The state of Pennsylvania is a very interesting place for a lot of reasons. But one of the things they do is they have a trauma-centered registry for the entire state. And so all the level 1 patients are coming in there. The second thing they do, which is very interesting, is in the state of Pennsylvania, if you get shot, they don't wait for an ambulance. They put you in a police car and they take you to the hospital as fast as you can. And so if you look at their gunshot wound numbers, their survival rates are better than other places, probably for that one reason, which is kind of interesting. And unfortunately, in Philadelphia, we have a lot of gunshots. But with that is, I looked at all the different populations and I said, okay, spinal cord injury, we need to get these people to our emergency rooms as fast as we can. The problem is there's a perception out there that a spinal cord injury is not an emergency. And so if you know any ER people, or if you're an emergency room patient out there, I would say, please get these patients to a tertiary care center for two reasons. One is we can operate on them earlier. They get a better life expectancy and better survival. But number two is a lot of the clinical trials we're doing have timelines on them. And some of them are coming down for pharmaceutical agents. They want them in the patients and they're trying to get them in at 8 hours. So it is something I think, push the patient to the emergency room as fast as you can. Now, with that said, and with me saying, oh my God, we try to get patients as fast as we can to the operating room, you have to be realistic. This is NACTN, North American Clinical Trials Network. I happen to be one of the PIs for it, but it's very interesting. We only got about 50% of the patients into the operating room as fast as we said when we look at the whole organization. So I think, this is me looking at it retrospectively and saying, hey, we need to do better for all of ourselves. So you need to look at your process. And at Jefferson, we've sort of have tried to streamline it. If you come into our ER, you go right to the MRI, you get a CAT scan before they even call the neurosurgeons. We scan their whole axis. We take them right to the right to the MRI, and we get sagittal T2s, axial T2s, and then bring the patient right to the emergency room. So again, we've tried to figure out at our place, and even with that said, we're not 100%, but we do believe that early surgery is a benefit. Do you guys still do traction? Probably not. Traction is Jefferson. We were probably one of the biggest places in the world for closed cervical traction. And we pretty much got away from it really for two reasons. One is there's a very big learning curve for it. Number two is it takes a while to do. If you do traction, you're probably good at it. You can do it in a couple hours. Most of the resident takes about 5 hours. And for me, that's all times while we're waiting for the spinal cord to be decompressed. The third thing is, even at Jefferson, and we used to hang a lot of weights. Like when I was a resident, we'd hang 100 and 150 pounds on people, which, you can't say in your boards anymore. But even doing that, the success rates were only about 93%. And so I can argue with you, at least at our place, we found it faster to take the patients right to the operating room and do an operative decompression. And this is not just a Jefferson, and this is not a US thing. Although we're doing well, if you look around globally, these other hospitals, other parts of the world are much farther behind us. So we're trying to help them along the way. And I sort of talked about this, so we can skip that. All right, next thing. And we're talking about spinal cord perfusion. This is probably, and again, I hate to say it, but the vascular guys probably taught us this one too. The vascular guys, everything is vascular. I don't know if Chris tortures you guys with that, but this came out and it was based on a paper by Vail. And this is the first spinal cord injury guidelines that said we probably should get our mean blood pressure above 85 to 90 with the spinal cord injured patients. And I'll be the first one to say there's not a lot of data on this, and there's numbers are somewhat arbitrarily picked. And I'm not saying that to make fun of the people that did it. I think it's their papers are fantastic. It's just, we need to do more work on what's the ideal blood pressure. I find it very interesting with hypertensive patients. Personally, I think we may need to put their pressures up higher, but we haven't figured that out. But I will show you this. So this goes back to my conversion rate, which I told you before. And I said, wow, we're doing great. But I also said, we're not totally sure why. Staskis was the timing of surgery we just talked about. So that came out in 2012. And you can see the improvement in conversion rate was happening way before that. And why was that? I kind of guess. I think it's because we started to have more modern operative treatments, but also I think that spinal cord injury guidelines came out, and one of the big messages from that paper was that we should use hypertensive therapy in these patients. Someday I'm going to figure out how to use Zoom. All right. Brian Kwan was a fellow of mine. He's an orthopedic surgeon, and he's probably the most neurosurgical orthopedic surgeon I've ever met. And I don't know, that's about as great of a compliment I can give you. And what he's looked at, and you guys all know this because you know it all from brain injury and the brain injury stuff. he's come up with the idea that we need to perfuse the spinal cord. And with that said, is what he's developed is we at Jefferson have always been massive, jack up their blood pressure by the arterial side. But he said, and again, this is an orthopedic surgeon, he said, well, why don't we drop their CSF pressure? And so what he's done is you can increase someone's mean arterial pressure by two different ways. And this is what he called the spinal cord perfusion pressure. You can increase the mean arterial pressures, which we've been doing for the last 20 years, and you get a spinal cord perfusion pressure of 65 in this case. However, the second other way to do it is to drop their CSF pressure. So we've actually now been switching over, and in our Asia A and other patients, I put lumbar drains on them, drains in them all to try to decrease their cerebral perfusion pressure. And this is why, and this is kind of interesting. I don't know if you remember your autoregulation curve or your Starling curve from back in medical school, but what happens if you look at a spinal cord, and this is a rat, for example, on the bottom row on the left is this is the Starling curve. And what happens is in this part of the curve from here to here, you have autoregulation. The interesting thing is when you get a spinal cord injury, that's these ones over here, this is a severe spinal cord injury. Your mean arterial blood pressure drops drastically, and more importantly, your autoregulation gives up. So it's a big problem in terms of, it's a big problem in how do you perfuse your spinal cord? And so with that said, I'm sorry, I'm trying to erase my annotations, which is not really how working that well. Okay. With that said, drum roll, there's a guy named Nick Theodore. I don't know if you guys know Nick Theodore. Nick Theodore's at Hopkins, and he's done a lot with spinal cord profession. He's got a Department of Defense grant. And this is a very interesting slide. So I'm going to take 2 seconds to go over it with you. And it really talks back about the perfusion of the spinal cord. So if you get a spinal cord injury, what happens is your spinal cord perfusion goes to the blue line here, and that is not good. So you get a decrease in the perfusion of your spinal cord, and we know injured neurons probably need more spinal cord perfusion. If you get a spinal cord injury and you put a lumbar drain in it, you get this a little improvement of blood flow. But again, you're not doing a lot because all you're doing is you're decreasing the venous vascular side. So you don't get that much perfusion. If you jack up the arterial pressure, that's the red line up here, you get some initial improvement of your perfusion, but then probably because you don't have an autoregulation, it doesn't work. The synergistic effect, though, seems to be if you increase the mean arterial pressure, simultaneously decreasing the venous pressure with the lumbar drain, you seem to get a better perfusion. And that's sort of where a lot of the theory is with the spinal cord injuries. So Brian, I was talking about before, set up this trial called the Camper trial. He published it in Neurology. That's why, and I made fun of Brian the other day. I'm like, this is one of the greatest papers that no neurosurgeons have ever seen. But it is a great paper. If you get a chance, read it. And interestingly, one of his main points was that if you looked at the patients that converted, right, or trying to get patients to convert, is that if you were able to keep their spinal cord perfusion pressures above 50, they had a much better chance of converting. And if you look over here, the relative risk of them converting, once you get to 50, which is the yellow box, it drops down significantly. Now, you could say, hey, Dr. Harrop, that's because the patients that were doing well in auto-regulating didn't have as bad of spinal cord injuries. And you are 100% correct. And I agree with that. But if you look at the big paper, there seems to be some benefit from this. And this is his protocol. And it's interesting. There's not really a protocol out there. A lot of people are starting to do it. No one really has a great protocol. Again, if you're old enough, you might remember the head injury trials. There was the group that would be continuous drainers, and there was the group that would monitor and drain it when it came to a threshold. And that's sort of where people are with the spinal cord injury trials. So I think that's something we're working on, and something that's kind of an interesting. this was, I'm trying to remember what this paper was, why I put it in here. Oh, this is, it's funny because when you're, this is Bijan Arab. I don't know if you guys know Bijan. Bijan's one of the guys at, uh, at Shock Trauma. And he wrote a very interesting paper, and it goes back to the question of when you operate on a spinal cord injury, you tend to do the operation, okay, all done, and things are great. The problem is a lot of patients have congenital stenosis, and the spinal cord swells when you get a spinal cord injury. And the question becomes are we decompressing enough? So he went out and he looked at his patients and he looked at, should I do an anterior or posterior, and what is the best thing to do to get CSF circumferentially around his spinal cord? And it was really interesting because what he found out is that you have a much better chance of having the spinal cord decompressed if you do a posterior laminectomy. Now, most of us would agree with that because if you look at we've all done tons of post-op scans on patients. Your ACDF scans never look as great as your posterior cervical scans. But there is some question about, how well do we decompression and how much they should, and can we do better on their cord? And that goes to the next question of, okay, so if we're going to do the spinal cord injury, how can we protect the spinal cord? And I'm just going to give you two quick little talks on that. So there's multiple different ways. When the spinal cord gets injured, remember, there are intact neurons typically that go through the area where the injury is. There's also demyelinated neurons, and there's also a cystic cavity that forms. And so that's a nutshell, very basic of what happens. The first thing I want to just really briefly mention is solumedrol and spinal cord injury. I just debated Mike Failings about this, so I kind of know a lot about steroids if anyone wants to discuss it offline. But this is Nactin. And after the second guidelines came out for spinal cord injury, the use of spinal cord steroids has drastically decreased in this group, who are mostly large academic centers. And that's probably because there's a question how beneficial they are. However, remember this is, if you believe the Nactin study, which I do, is it did get a 5-point improvement in motor score. It did have worse complications, but it didn't have a higher risk of mortality. So if you have an 80-year-old diabetic patient, I would probably say not a good person to use steroids on. If you have a 20-year-old healthy person who has a severe injury, you might want to consider it because, again, they might be able to get some improvement of their motor function. And this came to me one day. We did guidelines, and there was there's a tetraplegic patient in the audience who happened to be a rehab doctor. And they said to me, if I could get 5 points, I would risk my life. And I was like, "Ooh, that's pretty compelling to say maybe you should consider it." All right. Next drug is called Riluzole. Anyone heard of Riluzole? If you know anything about ALS, you've probably heard of Riluzole. It's a drug. It's a calcium channel blocker. This is the effect on Riluzole where it showed to, excuse me, this is a spinal cord trial we did where it actually showed that had an improvement compared to controls. The problem is we then went on and we just wrote a prospective randomized study, and you didn't see a great improvement in neurologic function. Interesting thing, and as I told you all about different spinal cord injury things, for some reason it looks like C5 palsies might be lower in the group if you use them. And number two is the pain seems to be better if you use Riluzole. So there's two areas we're trying to figure out down the road how involved they were. And that's sort of the study. Next thing I want to talk about is stem cells. A lot of people have feelings about stem cells. I would tell you, my patients ask me about them all the time. I would only do stem cells if I did them through a study, because there's two very big things about stem cells. One, they have to be pure. Two is they have to be alive. And the problem with a lot of these cells is once you take them out of the body or they make them, they die fairly quickly. And so there's a bunch of different studies on stem cells. I actually am a cynic about them, but I will tell you, I do believe they've improved the patients who they've been in trials so far. Okay. This is Asterius, who unfortunately did a study, and this is against controls, and they had a very good positive result. The problem is COVID happened when they were starting to do their second study. And these are all intraparenchymal injections. And so the hope is this gets back on track. but we haven't really heard from him. And again, here's a study. This is a poor young lady who had a spinal cord injury, kyphotic deformity, got fixed, and then went over to Russia and got olfactory cells put in her nose. I mean, olfactory cells from her nose, and they got Schwann cells, and they put them in her spinal cord. The problem is the picture on the right is when she came back, she was having increased pain, and they thought she got a tumor in there. And they did the biopsy, and I don't know if anyone remembers her histology classes, but it turns out that is respiratory epithelia. So the stem cells she got were highly contaminated with epithelial cells, and she basically got a big mucosa, a big mucus collection in her spinal cord, which is probably not that good. This is the Miami study's been doing Schwann cells, again another area which is looking somewhat promising, hasn't been out. I do want to talk about this study. This is the in vivo study. I was involved in this study. It went through a safety study where it was shown to be a safety, and then it just recently completed its randomized trial. There was no different, very small study. It was 20 patients. 3 people converted in the control group, and only 2 converted in the in vivo group. The interesting thing, and this is, hopefully this works. This is what happens. This is the traumatic spinal cord, and this is a myelotomy that you have to do to put the graft in. So basically, you're putting a graft in there, and you can see as you go and open up the spinal cord, all this heavy proteinaceous material comes out under severe pressure. Which, remember, we're trying to perfuse an injured spinal cord. And so if you look at this, this is after they decompress it. Now the spinal cord is pulsating and there's no pressure on any of the neural elements. Then you put this graft in there. The interesting thing about this study is that if you look at the conversion rates weren't at 9 months or a year, as you would expect if it's going to be the neurons following the stem cells up through this tract. It was actually more immediate, which to me believes that the myelotomy is what was important. And remember, unlike the brain, when you decompress the dura, the brain can expand. The spinal cord has a very thick arachnoid layer around it, so the spinal cord cannot expand. So if it has a hematoma in the middle of it, it expands to a certain portion, and then it sort of goes on and necrotizes itself. And so the other lesson in life you're going to learn is whenever you think you're really bright, go back into the literature because someone else has already had your idea. This is a paper by Dr. Allen from Philadelphia where he did the exact same thing in dogs. And he showed that a myelotomy significantly improved the patient's neurologic outcome versus non-myelotomy in spinal cord injury models. So I think there is something out there with this. You're probably going to see intramedullary surgery more in the spinal cord injured populations down the road. This is hypothermia. The guys in Miami, I'm involved in this. Basically, the thought process is if you drop the blood pressure, drop the temperature of these patients, not really low, but down to 92 degrees, slows the metabolism in the spinal cord and improves their prognosis. So we're in this study, and actually the initial results have been somewhat positive. One of the leaders out there is a lady named Susie Harkema. And Susie Harkema has done a lot with spinal cord injuries, this is where I coming to the end of my talk, but I really, reach out to tell you the neuromodulation people have unbelievably pushed the field forward. So she started with the 23-year-old guy was a C7 Asia B, and they put him on this conveyor belt over and over and over, and then they stimulate the spinal cord. And what they found is they can get the patient to develop neuronal tracts and start with spontaneous motions. Most people believe now is the stimulation stimulates the dorsal root ganglion and causes some upper motor neuron interneurons to reconnect. But it was a proof of concept. She has about 30 people in this study now, and it's really pushing it forward. We're actually doing our own study looking on this technology, but probably one of the most interesting fields. Now, what a lot of people don't know, and this is her work, and she gave me these slides, but it's also shown in several different areas of spinal cord injured populations. Bladder functions improved. But one of the big areas, which I thought was autonomic dysreflexia, which if you know the spinal cord injured population is extremely morbid, has been significantly improved from this. So there's some question is, can we use that to treat these people down the road? And this is Ali Razai's thing, and this is really fascinating to me. So I'm going to spend 2 seconds with this. But this is a C5 Asia A, complete paralyzed guy, couldn't move anything in his arms and legs. And so what they did is, and I'm going to do this kind of quickly, they put a Utah array, which is an electrode, into the brain, into his motor strip. And they did that by using a functional MRI to figure out where his motor strip was by having him thinking of moving. They then put a receiver in and connected to a computer and then had him think about moving with giving him electrical stimulations. And so what happens is the computer accesses his brain. He thinks about it, sends an electrical signal to the computer. The computer then stimulates the nerves in his arms and he gets a motion. So hopefully this works. This is actually about 3 years old now, but this is when they were just starting. He's thinking about moving his hand and he gets some motion. And this is their first version of this. And this is about a year later. And remember, this is a completely paralyzed person. And just by thinking about it and using the computer to interpret the electrical simulation, he's able to do all these things. Now, the most impressive thing to me is if you're a functional person, he's got that bolt sticking out of his head. And I know, I used to do shunts and I had like 100% infection rate. And this guy's walking around with a bolt hanging out of his head, which is a metal conduit. And for some reason, it doesn't seem to get infected. Okay, lastly, I want to talk about, this is, again, the guys in West Virginia who's with Ali Razai. Peter Conrad went and joined him. But what they did is, this is a transected cat spinal cord. And if you can see those little hair filaments in there, those are actually wires. And so what their thought was is, can I put a wire into the spinal cord, stimulate the wire, and get the appropriate neurons to fire? And so this is the cat and exactly what they did. They're stimulating the spinal cord and they're getting a reliable pattern generator and ambulation. And so if you think about this, we're kind of up to where the Luke Skywalker is, where we're able to start putting things into people. And so my thought with spinal cord injury is, I think the modulation people are much more ahead of us, and they're going to be bypassing the spinal cord in the short term as we try to look for future cures. And with that, I thank you.
Thanks, Jim. That was great. I think Elon Musk is in your camp based on this week's news reports
I
that
know
he's
he put
bought
the first
into.
brain bleed in. That's pretty.
Yeah, and of course, you know that the electrode side of that now is a stentrode, can be a stentrode in the sagittal sinus, but the spinal folks may have some comments on the other parts of the talk.
Yeah, Jim, thank you for this talk,
Hey,
and I really appreciate you going actually through the history and showing us some landmark papers here. So one of the things, you pointed it out a little bit, right? If you look at the statistics trial, early is not really early in my book, right? Early is, even 12 hours. Like early is, as I said, you do it in the middle of the night, right? You don't sleep on it, and there are some, I know we all would like to see in a best case scenario, but if I do a multi-level fusion at midnight, it takes me twice as long as I do at 7 in the morning, right? I bump my elective case. So to talk me through about this a little bit, do you really do it at midnight?
No, we really do it at midnight.
Do you bump your first elective case the next day?
We really do it at midnight. And it's there's two different interesting things. The number of acute spinal cord injuries is drastically down, which is unbelievable at our place. We used to I was on call last weekend. We had no spinal cord injuries, which is a different world than when I grew up in. So that's been kind of nice from the early surgery part. Number two is the residents actually have completely converted, and they think, they torture me every now and then because there'll be a central cord injury in an 80-year-old guy who's anticoagulated, and they'll be like, all right, we're calling the OR. And I'm like, stop. The guy's got a little hand weakness. Why don't we get a cardiologist to see him? And I think that population is totally different than the guy with a cervical fracture dislocation. So the second thing I totally will tell you about is thoracic injuries, I think, are also a different animal. Fracture dislocations in the thoracic, much higher volume, much higher thing, a lot sicker patients. So those ones we try to do in 24 hours, but probably wouldn't rush that person into the operating room in the middle of the night, unless everyone says everything green light looks good. But really the cervical ones is what I'm talking about. And those are the ones that we usually do. And usually it's a younger population with a fracture dislocation.
Exactly. That's your jump facet, right? Mostly that's your.
Now, to be totally fair, we
Mhm.
have a complete separate nursing group, which is spinal cord injury nurses, because we run about 8 spine rooms a day. And so we have a call for the nurses that do spine. So there's always at least someone who knows what they're doing, usually 2 of them who are there. So it makes our life a lot easier rather than, and trust me, I know exactly what you're talking about, being there with the OB-GYN nurse who's like, oh, I've never seen a drill before.
Yeah. And so you're talking about the traumatic fracture dislocation, central cord, you're doing the next day, or you
Central
decided by the
cords.
patient?
So I actually have a whole debate about that. I'm debating, I have to do early central course with John Harrop, and it's so funny. They never give me the same debate. So 2 weeks ago I had to do early, and now I have to do late. And I'm like, John Harrop's just going to go get my talk from last week and trash me. But with that said, if you look at the data from central cord injuries, it's not as great for neurologic recovery. I mean, remember, you're an Asia D to start with if you're a true central cord injury. So how much better are you going to get? And then you have to weigh that against a very elderly population that tends to be sick. So those ones I tend to try to do on a daylight hours after we get them medically stabilized and make sure every other issue's stable.
Yeah, but we have it, like our orthopedic surgeons take them in the middle of the night. We don't tend to do it, and then it always creates confusion on ACS and in the emergency room a little bit. Well, why you are not doing it in the middle of the night? Why you're doing it, in
No,
a delayed session? So
I agree with you that one, and that's it's sort of, and I love my orthopedic colleagues, but everything in life is black or white, and so I'm kind of like, you got to look at the patient and be like, okay, how much are they going to get from taking them in the middle of the night? How much it's going to cost them? If you go back to the general surgery literature, it is pretty impressive the mortality of operating at night on an elderly person.
Yeah.
So it's kind of like, okay.
Thank you. I have many more questions. I could keep talking to you, but I'm gonna leave some room for the other faculty. Great talk. Really appreciate it. Thank you.
Thanks for having me.
Good morning, Jim. Thank you so much. I'm Steve Papavasilio. I've been at the BI for over 20 years and primarily doing spine, directing the spine center here as well. I like your comment about the ADD. This is something I frequently tell our residents. I keep telling them I have so much ADD, I need to do a lot of things, and I need to keep asking you questions, in fact. So I know they're hearing it, but that's part of my excuse to keep asking them different things. The issue with the lumbar drain, you didn't say a lot. I know that's been a controversy, especially with the cardiothoracic literature that's like 30 years old.
Uh-huh.
And it seems to be resurfacing a little bit. Is there anything more you can tell us about it? Are you doing something? Do you have any preliminary results?
So I'll break it down for the residents, so they might not know this. The cardiac literature, particularly in the old days, we used to do aneurysms, and what we would do, the cardiac surgeons would do aneurysms, and they would go in there and they would take all the perforators of the aorta down at the base of the spine, because they would go in there, scoop everything out, and put a graft in. And the problem was, invariably, in some percent of the patients, they would go paralyzed. The vascular surgeons have done a bajillion prospective randomized studies that have shown absolutely you should put a lumbar drain in these people. Even though they're anticoagulated, they do much better. Their incidence of paralysis is so much lower if you put a lumbar drain in them. That's somewhat now they're putting stents in them all and everything. We don't see it as much, and they don't ask us anymore. There used to be a huge fight with the neurosurgeons. I'm not going to go down there and put the lumbar drain in. And so we did a huge literature review, and it's absolutely justified. So now that they do it mostly endovascular, we haven't seen it as much. But the second thing is the spinal cord injury drainage people, I believe it. It makes sense to me. I'm trying to study it. And so over the last year, we've been trying to put the drains in patients. We don't have the right protocol yet, or I don't think we have, because ideally to me, as you do the surgery, you drop the lumbar drain in the OR. There's still some nursing issues and education, but I always go through the adage of, well, if it's me, what do I want done to me? And I'm telling you, if it was me, I want someone to put a lumbar drain in me. How long do you do it? Great question. We think 5 days, and that's based on really no literature except for the hyperperfusion data. Because the longer you leave it in, after 5 days, we wrote a paper that showed drains get a higher risk of infection. I don't know if that answers your question. Brian Kwan is the guy who's most interested, and I've talked to him at numerous times. If anyone's in the American College of Surgeon, I'm trying to run a forum we're going to have on medical management. And I think we in spine, particularly in spinal cord injury, have not done as well as our other colleagues taking care of the ICU patient. We've sort of defaulted it, at least at our institution, we defaulted it to general surgeons who don't have a lot of interest in neurotrauma. So we're sort of trying to take it back. And I think a lot of these patients could be better managed with hypertensive therapy, pharmacologic agents, and lumbar drains.
Yeah, the metabolics. It's kind of like our travel through ischemia
Right.
/ stroke. That for years there was many agents used. Now we have devices, but you know there's still lots to be done with moderate hypothermia, magnesium. There's a bunch of things that are neuron sparing that I think spinal people are working on, and trials are probably the way to answer it, yes or no.
Absolutely.
But I see that our time is just about up. If there's any last minute questions, we also have Dr. Harrop's contact info if anyone needs it.
Yeah, I'm
But,
happy to, anyone wants anything or papers, let me know. I'm happy to share with any.
we
have
can
my
get them in
slides,
touch
too.
with you. And I just want to thank you again for taking the time to do this. It was a great run through, and I know it's going to generate discussion later on today. And very much appreciate you taking the time to do it and for being here.
Absolutely. Thanks for having me.
Thanks very much. Take
Thank
care.
you.
Thanks, everyone.
Thank you.